Ahmed Kamel, one of our pioneers, migratory birds, to talk about interesting subject, which is endovascular arteriovenous fistula creation for dialysis patients, indication, technique, and outcome. Please, Dr. Ahmed.
Thank you so much for the introduction, and thank you for the organizing committee for the invitation. We're going to shift gears and maybe shift gears from interventional oncology to dialysis interventions. So we're going to talk about the percutaneous fistula creation. These are my disclosures. I'm a consultant for these companies, and I have research commitments with them. In terms of patients who need dialysis, the Kidoki guidelines, the new Kidoki guidelines advocate for giving the patients the right access for the right patient, for the right reason, and the most importantly is in the right time. And that's very, very important. And it's not important just to create a fistula, but to create a functional fistula that can be used, because you can easily surgically just join an artery with a vein, but then it's not working well. So this is, surgical AV fistula is the standard of care. However, it has lots of problems, and it depends where you read from. These are the numbers that are available. Failure of maturation is up to 50%. So you create a fistula, but it doesn't mature. So how useful is this? It's not useful at all. Time to maturation takes almost like sometimes 9 months. Again, depends where you read from, 4 to 9 months. During that period of time, the patients are having their central lines, and we all know that these central lines are very damaging to the central circulation, the central veins here. And once you damage these central veins, even if you create a fistula, it won't work. So that's also another problem. So that's why 80% of these patients initiate dialysis while having these central lines, whether it's a perm cath or a Quinton. Interventions per year is almost like 3 to 4, whether it's balloon dilatation or even thrombotic occlusions, like we do declots or balloon angioplasty. And even 30% of the patients in America, they actually refuse even to do that because they get like appointment fatigue. They keep going back and forth between a surgeon, interventional radiologist, they do Doppler and come back again and so forth, so they get tired. The reason these things happen with surgical fistula is that it creates a end-to-side anastomosis, as you can see here. So with these, there's a lot of shear stress because of the torsion of the vein, as well as the junction itself creates a lot of shear forces here, which leads to neointimal hyperplasia. If you just Google, dialysis fistula, just like I did here, okay? This is what you're gonna get. You see all these very dilated aneurysmal, very disfiguring to the arm. This is what the surgical fistula is gonna create. So the creation of dialysis fistula using the endovascular technique or interventional technique has several benefits, and it's a new innovation. So first, it expands the anatomic options for AV creation. Number 2, it enables multiple cannulation options for these patients, and it avoids the surgical scarring and minimizes the disfigurement in the arm, as we're going to see in a second. So let's talk about the first one. We're going to talk about each one of those. The first is the expanding the anatomic options. These are the usual surgical options. You can get a radiocephalic, brachiobasilic, or brachiocephalic, and with a brachiobasilic, you're going to get like a superficialization of the vein. The AV fistula is done through an ulnar artery to ulnar vein fistula or radial artery to radial vein fistula. So you're basically adding 2 extra sites to the already existing surgical sites without affecting them. So even if it fails at one point, you still go back and do a surgical fistula. This is how it is, again, the important thing here in this diagram is the perforator. So let's talk about this. Here's the, the artery, brachial artery, going down into the arm, and then it goes and divides into radial and ulnar, and then the ulnar divides into proper ulnar and interosseous. This is where we create the fistula. We create it between and there's veins, of course, that accompany these arteries. We create the fistula between the ulnar artery and the vein here, or the radial artery and its vein. And what happens is the blood flows from the brachial to the ulnar and then into the vein, and on its way back, it meets this perforator. The perforator here carries the blood from the deep system, which is the ulnar system, which should drain into the brachial. It carries it to the superficial system, which is the cephalic, and the basilic. So if the patient does not have this perforator, which happens in 20 to 30% of the patients, they don't have it, so you cannot create that fistula. So this is really essential. So again, it goes from the brachial down to the ulnar, and then from the ulnar artery to the ulnar vein, back into this perforator, and then upwards or superficially into the cephalic and basilic. And when that happens, that cephalic or basilic vein, they start to grow because now they are arterialized, and they can then be used for fistula, as a fistula. This is again as a close-up. Here is where we create the fistula. Here is the perforator that should be present in these patients. Patient selection is very easy. It's the rule of 2 millimeter. So the artery, which is the ulnar or radial artery that you're going to use for the creation, should be 2 millimeter or more, of course. The vein should be 2 or more millimeters. The perforator also should be 2 millimeters, and the outflow vein should be 2.5 millimeters or more. This is how the perforator looks like. This is the radial vein, and this is the perforator that carries the blood superficially to the antecubital vein here, which then divides into cephalic and basilic veins. And of course, you have to do a Doppler study to make sure there's no valves or anything in that perforator. Otherwise, you'll have to balloon that. We'll talk about that later. Procedure is very simple. There are two FDA-approved, so far, two FDA-approved devices. The first one is the Wavelink, and the Wavelink is basically two catheters. One of them will be in the artery, the other will be in the, one in the vein, and the other will be in the artery. The one in the vein will have this electrode, while the one in the artery will have this backstop or ceramic plate. And these are sets of magnets here that help approximate the artery with the vein. And what happens here is these two catheters are connected to this bogie or the RF generator. It generates RF energy, which basically connects or dissolves the walls of the artery and the vein. It creates a fistula. This is just how it looks. As you can see, this is before. Then when you activate it, they join each other. Here they are touching each other, which means the artery and the vein walls are gone now. There is a fistula created. And we'll see some more images about this. So for this to happen again, you can access both the artery and the vein at the brachial side, but you can also do radial or ulnar access. It's just a video here that shows you a diagrammatic video, just to show you how it works. So what you do is, I'm going to skip this for the interest of time. This is how you pass a catheter into the artery and another catheter into the vein. And these sets of magnets here will help place these two catheters side by side. As you can see, it approximates them. These are magnets. And then these two are very, very close to each other. You pull the wires back, and then you activate the device. That creates a hole here between the artery and the vein. And now you remove both catheters, and then the blood flows through that hole from the artery to the vein, and then through the perforator into both the cephalic and basilic veins. So this is just a real case. As you can see here, this is the ultrasound of the brachial artery, vein, and the nerve. You access the artery and the vein. Here's accessing the artery, and this is the arteriogram showing, again, the brachial artery, which divides into ulnar or common ulnar and radial, and then the ulnar divides into interosseous and proper ulnar. For the vein, we access the vein, and you can see the catheter is here. When you inject contrast, the blood flows through the perforator, which is here, back to the basilic. Here it is predominantly basilic. Sometimes it's either predominantly basilic, cephalic, and sometimes it's dual veins, like two veins. So we put both catheters, one in the artery, one in the vein, and then when we activated them, as you can see here, there is no space anymore between the electrode and the ceramic end plate. It's gone, which means the fistula is created. When you look here, here's the fistula. We're injecting contrast from the artery. It goes through the fistula, back into the vein, which goes through the perforator and back into the basilic here. The cephalic is very, very minute, which is this one. In addition, we want to force the blood to go into the superficial system through the perforator. So we usually coil one of the veins, which is the deep veins, the brachial veins. There is usually 2 or 3 of them. We call one of them to force the blood to go to the superficial system, which enhances the maturation of the fistula. This is how the fistula looks like. Again, that is the connection between the artery and the vein. This patient went to dialysis 4 weeks only after the creation. As you remember, when I told you this, it takes 4 to 9 months for surgical AV fistula, sometimes to mature, it depends where you read from. Ellipsis is the second FDA-approved device. It's basically an ultrasound guided only, so it doesn't use fluoro. It's a handheld device, 6 French, so slightly bigger because the other device is 4 French. It has this hole here, or like a gap between the two, at the tip here, between these two sets at the tip of the device. And what happens here is when you pull that trigger backwards, it actually approximates these two metal pieces together. And then when you trigger this device, it actually melts, uses heat to melt the walls and fuse them together. This is how it's going to look pathologically. They are fused together. It's called TRAD because it's a thermoresistant anastomosis device. This is how it works. I'm going to just show you a diagram and the ultrasound accompanying picture with it. So you have to access the perforator, and then through the perforator you access the radial artery. Again, one of the disadvantages here of this device is that you can only use it for the radial side. It doesn't apply to the ulnar side. So if the anatomy is not favorable on the radial side, then you have lost these patients. In other words, the qualification of patients for this device is slightly less than the wavelength. Once you access the perforator, you start accessing the radial artery. And here's the image of the tip of the needle inside the artery. Then you pass your wire. Here is the wire. And then you have to put your 6 French sheath in order to accommodate the device. Here's the sheath, and this is how it looks like. Then you remove the inner dilator of the sheath, and then you, over the wire, you place the catheter, the device. Here's the device, and you can see it inside the artery now. And then you place it in such a way that this gap is bridging both the arterial and venous walls together. And then you activate the device by pulling this trigger back, like I told you, so that you can approximate these two metal parts together. And then you activate the device by initiating the thermal energy. As you can see here, you will see, just like ablation, you know, any ablation anywhere in the body, you will see these air bubbles. And then you will get this fusion between the artery and the vein. And of course, there's no fluoro here, but there's ultrasound, so you can use ultrasound to, confirm that you created the fistula. Here is the radial artery. It goes through this fistula into the perforator. And then you also have, and this is, you can measure the size of that as well. You also can measure the velocity in the brachial artery, and it's recommended if the velocity in the brachial artery is less than, it should be more than 500, the volume flow, sorry, not velocity, volume flow. If the volume flow is more than 500, then that's okay. It's associated with, with good maturation of the fistula. If not, then you can balloon dilate that with a 5 millimeter semi-compliant balloon. This is just, again, what we talked about, the difference between the two devices, so we're going to skip that because we talked about all these items. In terms of cannulation, again, it expands or enables multiple cannulation options and expands that also. So as you can see here, for brachiocephalic, this is where you can cannulate. For brachiobasilic, this is where you can cannulate. But for the endo-AVF, which is what we are talking about today, again, you can have either one of them or both of them. So it expands your cannulation options. And when you do that, then the longevity and the patency of the fistula itself is actually increased, which is in favor of these patients. Again, this is how it looks. You can get you can actually do also split cannulation. So you can put your 2 needles here, or you can put 1 needle here and 1 needle there, just like this video is showing here. They are split cannulating this vein, this patient, as you can see here. Again, for the interest of time, we're going to skip this. The third one is to avoid, the scarring and minimize disfigurement. This is after 2.5 years. You can see the patient's arm is not disfigured like we have seen at the early, slides, where you have seen this aneurysmal dilatations in the draining vein. Follow-up of these patients is very simple. You do ultrasound Doppler in 1 week just to see if there's any complications and to assess the patency to make sure it's still patent. Then you do it at 6 weeks, which is what I do. It's 4 to 6 weeks, but usually 6 weeks. And you want the brachial artery. This is different than the surgically created fistula. The criteria for maturation is different. The criteria for maturation is that the brachial artery volume flow should be more than 500 milliliters per minute. and the diameter of the vein should be more than 4. Surgical fistula, we know the rule of 6. It should have more than 600 flow in the draining vein, so it's a totally different criteria than this one. And like I said, most of the time you will basically get that at 4 to 6 weeks, which is very, very different than the 4 to 9 months that you get with surgical fistulas. Outcomes, there were 2 studies that were done to get these 2 devices approved, which is the NEAT study for the wavelength and the pivotal study for the ellipsis. Both studies showed high technical success, high safety profile, low incidence of serious adverse events, and high maturation rate, and the high rate of cannulation and dialysis. So this is the NEAT study by Locke from Canada, again showed really high technical success, just like we mentioned, and the cumulative patency is great, running around 85 to 90%. This is a systematic or meta-analysis for almost like 7 studies, including 300 patients. The technical success, as you can see here, is 97%. The 90-day maturation rate is 90%, which means at 3 months, 90% of these patients already matured. Again, patency at 12 months, still patent, still functional at 85% of these. This is the EASE trial, which was done in Germany, England, and Paraguay. The EASE studies, EASE 1 and EASE 2 were in Paraguay, and then the European study was in England and Germany. Again, showing great results, and 78% of these patients were intervention-free at 6 months. I'm going to finish real quick in a second. So cost effectiveness, because again, there is cost associated with this. It actually reduces your post-creation interventions 6 times compared to surgery, which is associated, again, in American dollars for the first year, $11,000 cost savings. So it's actually a cost-saving device or technique. I'm going to also skip this. So in conclusion, sorry, I'm probably ran over time here. So in conclusion, Endo-AVF system creates a functional AV fistula without open surgery. Endo-AVF systems, they offer 2 additional anatomic sites for dialysis AVF creation. Thorough patient screening and good planning for the procedure is key for success. Thank you so much.
Thank you, dear Dr. Ahmed Kamel, for this nice presentation of this innovative technique. I will ask you